Good afternoon, everyone. I would like to call Dr. Usha Vishwanathan ma'am to chair the next session. Dr. Usha Vishwanath ma'am is a diploma hospital administration. She is a professor and head of obstetrics and gynecology in Sri Ramachandra Medical College, Srihar. Head of patient safety and quality at Sri Ramachandra Hospital, SRMC. She is an ABH assessor for full and entry level accreditation. Designed mobile app Suraksh for intrapartum monitoring of patients. Awarded prize CHO Tech for Suraksh Healthcare Innovations category. Secretary for Sri Ramachandra Center for Women's Advancement. Secretary for UNESCO Bioethics Program for Srihar. Awarded the Diploma in Hospital Administration by National Institute of Health and Family Welfare, New Delhi. Coordinator for a COM program for MBBS students and instructor for Advanced Life Support in Obstetric program. We welcome you, ma'am.
Thank you very much. Very happy afternoon.
Your speakers, Dr. Sridevi, ma'am.
Okay, thank you. A very happy afternoon to you all, and it gives me great, immense pleasure and pride to be here on the 10th year of Smart Srihar. Wishing Professor Sanjeev Reddy sir and Professor Radha and Mona and the team greater accolades. And sir, may you unleash several generations of competent, ethical professionals in reproductive medicines for several years to come. And let me now go on to the introduction of the speaker. It's our own girl, Dr. Sridevi. And can we have it there? Can we have the slide for the speaker? Okay, Dr. Sridevi has finished her MS OBG. She's a fellow in fetal medicine, and she's a consultant in Pinnacle Hospitals and Pinnacle Women's Imaging Center at Visakhapatnam. Over to you, Sridevi. The stage is all yours. The topic is ultrasound in endometriosis.
Very good afternoon. I would like to thank Dr. Reddy sir for the invitation. And I still remember I was his assistant in 2004-05 when the SMART was just started. And we always used to struggle to see the follicles then. So I think ultrasound is one of the modalities which helps us to see what is happening inside. It is like an extended finger for all of us. So the topic for me today is endometriosis. We all know endometriosis is an ectopic location of the endometrium, and it is seen both in the normal and women with infertility. So now we should know who are the ones who needs treatment, or is it just a simple endometriosis, or do we need to look something more? Coming to the very basics, infertility is a symptom, it is not a diagnosis. That means the couple comes to us that they have difficulty in conception. So unless you are very good and accurate at your diagnosis, the proper treatment choice you give doesn't give us a good outcome. So does the presence of endometriosis affect fertility? Yes, we have many studies, but we have seen many women with pregnancy, the endometriotic cyst. When we do the cesarean section, we see endometriotic spots. So that means that all the women with endometriosis, or the endometriosis doesn't lead to infertility in all the women. So how does it cause infertility? It's many factors, starting from the oocytes and the tubal relationships and the endometrial milieu. Everything has the effect of endometriosis. So coming to the diagnosis, the laparoscopic surgeons, they say surgery and the histology with the specimen is the best. Yes, we all agree with this. And the clinicians, they feel that the clinical diagnosis, when you don't see the disease, but when the patient is complaining something, they say that is the best way to diagnose. Yes. And people who does more of ultrasound or pro ultrasound feel ultrasound is the best. But I say, I think we are all, whoever is best at looking at the things, they can see things more than the other person. So today in my lecture, I'm going to show how best we can use ultrasound to see the endometriosis. It is not something is best, something is better than other thing, but the modality when you use more effectively or efficiently, you will be able to see things which we thought we cannot see. So is the scan in endometriosis something different from the regular scan we do? Yeah, the pelvic regular ultrasound, we see the uterus, ovaries and adnexia, but that doesn't suffice for the endometriosis when seen. So for endometriosis, now we have guidelines, we have consensus how to do a scan. The step 1 is you have to examine the uterus and the ovaries. The step 2 is site-specific tenderness and the mobility. It's very, very important to check the mobility. And we are all, I think, gynecologists good at talking. So this is one place where you need to talk and do the scan. The interactive ultrasound leads you to where the problem is. And step 3 is the obliteration of the pouch of Douglas, the sliding signs, and 4 is a search for the DIE nodules. So the benefits of transvaginal ultrasound is, first thing is we'll be able to pick up from the women who have symptoms whether really they have a problem or not, and assess the severity of the problem. And I'll show you some of the areas which anatomically, surgically it is not feasible to see. And we can avoid an invasive surgery just for the diagnosis, and we can keep the surgery for the treatment purpose of view. And it is very simple, affordable, and patient's acceptance is better. In the era of ultrasound, I think the surgeon should have the full information about the severity and how the disease mapping is there, so that we can plan the surgical team, and with the medico-legal issues, we can take a targeted informed consent when we are actually expecting some problems. So the phenotypes of the endometriosis, that means how it presents. The simple one is the endometrioma, or it can be a peritoneal or a DIE lesion or adhesions. So I think and I believe that once you know normal, it is very easy to say which is not normal. So this is a video of normal uterus, and the journey starts from vagina, not from the cervix and the uterus. You can see the probe anterior fornix, how the pelvic, the bladder is actually moving apart, and you can see uterus is freely mobile in the pelvis. The same thing we have to check with the ovaries also. The ovaries should be happily moving around, and it is not one side. The superior aspect, the inferior aspect, medial and lateral aspects, everywhere the ovaries should be freely mobile, and both sides you need to check. And this is the kissing ovary sign which we always hear. It's nothing but both the ovaries you can see in the POD attached to each other and the posterior aspect of the uterus. So it is like, the whole thing is stuck to each other. And dog ear sign is one thing we see because the uterus is retroflexed. You can see it is in the shape of the dog ear. This is because the posterior aspect is attached. You can see the endometrioma here, and it is pulled backwards. It's fixed there. And the posterior wall adenomyosis is the most common picture we see in the patients with endometriosis. So the typical endometrioma is a unilocular cyst, we can see here. And the cyst contents are homogeneous. And the cyst wall is thick, and we say low level or something, but it is uniform inside. And when we put the color, we hardly see the color. The color score, because any ovarian cyst, we have to speak on the IOTA guidelines. So it's a unilocular cyst, thick-walled, the color score is 1 or 2. But do we always see the same picture? Sometimes we see the wall nodularities like this. This is not to be worried. This is nothing but the cholesterol deposits or the blood clots. So this is a typical feature of the endometrioma. But there are, we don't always see this kind of picture, but sometimes we see this kind of multilocular cyst, and it is not homogeneous, but it can see heterogeneous. That means some are bright and some are not. And when we put the color, we can see some amount of color. Or sometimes we see the cyst which has acoustic steaming in some of these endometriomas. Yes, this is also a case of endometrioma, which is atypical appearance. This is a kissing ovaries, which I have shown earlier. But you can see it's not the same homogeneous appearance which we have seen in the previous case. And here again, it is not typical, but you can see white thing. We should not be worried. This is something as a papillary projection. It is nothing but the bleeding inside the cyst. So when you put on the color, any bleeding, it doesn't pick up the color because it's not the live tissue inside. So the atypical endometriomas can be multilocular, not ground glass, what we have always taught about, and a retracted blood clot can be present. The papillary projections with vascularization is a common feature we see in pregnancy, especially in the second trimester of pregnancy. And the chances of these endometriomas undergoing malignant transformation is just 0.3 to 0.8%. And this is the uterus picture. Commonly we see in endometriosis, that's a posterior wall adenomyosis. So now I'm moving little deeper into just not the ovary, but what else we want to check when we see women with the endometrioma or symptoms which are suggestive of endometriosis. The endometriotic lesion, which is infiltrating deeper than 5 millimeters under the peritoneal surface, are called DIE nodules. So now we have conscience statement, how we can see them, how we can label them, and all these things which I'm going to talk. So transvaginal ultrasound is a non-enhanced one and tenderness guided. And sonovaginal ultrasound, yes, I personally use a lot of gel vaginal sonogram from past 4-5 years. It's very simple. The same gel what you use to do ultrasound, just take 20 cc syringe and put it in the vagina. And when you do the scan, all the vaginal lesions, polyps, septate vaginas, any lesions within the cervix and the vagina, you can see it very well. So the symptoms actually lead us where to look at. So the endometrioma can walk either anteriorly, superiorly, inferiorly, or posteriorly. But when do we say this is an endometriotic nodule? If the nodule is hypoechoic with the diffuse borders, it should be firm, and when you put the probe at that point, the patient should feel the tenderness, and they are not much vascularized. And the bowel endometriomas, though we say Indian head sign is common, I can show some pictures how varied presentations will be there. And bladder endometrioma, it's a round comma-shaped one. So we are going to see systematically anterior and the posterior compartments. So the anteriorly, what all we are going to see, this is a normal one. We can see this is the vagina. When we come inside, you can see how the bladder is actually pushed away smoothly, and this is the anterior fornix, and the things are moving quite well. And then the bladder evaluation, you should put your probe near the introitus, so you can see the urethra here, and then you can see the walls of the bladder. For urethral tracing, you have to go just little laterally from the urethra, and then you can have to just twist little bit, and you can see the ureters here like this. So when do we say there is a bladder adhesion? This is a case of previous LSCS where you can see the bladder is not moving here, it is actually adherent at the level of the UV fold. And this is a case of bladder DIE where you can see the nodule here. Actually, this is a case of post-hysterectomy. I just kept it for the presentation's sake. The one ovary is retained, the other ovary was removed. And she had hematuria every month, and this is the bladder DIE nodule. So when we start learning and looking at the things, I think it will what the mind knows only the eye sees. So we have to look at these pictures and train ourselves to see the things. This is the urethra, this is the bladder, and this we can see it's a gel vaginal sonogram. You can see gel in the vagina which I had put, and this is the ureter, and you can see a DIE nodule here. This is the DIE nodule. So moving to the posterior compartment, we can see what all the things we have to see in the posterior compartment. This is the rectum. You can see the rectal wall, how it is sliding. Now your probe, which is actually facing anteriorly, you have to face it posteriorly. So you can see that, and then we are actually near the anterior lip of the cervix, posterior lip of the cervix. So this wall is clear. Then how do we evaluate the POD? Zoom the image should be more than 50%, so you can see so clearly, so well how the posterior fornix, you are into it, and the uterus is actually moving upwards. So these are the rectovaginal septal DIE nodules. This is how these nodules look like, and this is again a gel vaginal sonogram. This is the gel inside the vagina, and this is the nodule in the posterior POD nodule. And coming to the uterosacral DIE, now lot of literature, lot of studies are coming with the gel vaginal sonogram. Now they're putting the saline and then into the uterus, like how we do tubal evaluation. Once the fluid is inside the peritoneum, they are actually looking at the nodules inside, and these two are the nodules of the uterosacral ligaments. So segments of the rectum, when we see the DIE nodules, there is varied appearance. You can see here how, when we are tracing, how the normal bowel wall looks. As we go up, this uterus is retroverted, and then we can see the bowel is adherent here, and as we push up, this is normal bowel, and this is the bowel DIE, where as we go inside, this is a normal bowel, and this is a bowel DIE. Yes, this is the bowel DIE nodule. That's a small one. Here you can see very well, this is a little bigger one. We can see how it is attached to the posterior wall of the uterus. And this is another case where you can see the bigger one. This is typical, that Indian headdress sign. So the bowel DIEs can be regular in outline, or a comet sign, or Indian headdress sign, depending upon the severity. Because it's more severe, there will be retraction, and there will be the Indian headdress sign because of the fibrosis. So these are the three appearances which we have seen. So whenever we see a bowel DIE, we need to measure it in 3 orthogonal planes. And if you see more than 2 lesions, measure from one end to the other end of the multiple lesions, and also measure from the lower end of the lesion to the anal sphincter. So the diagnosis is not the end in endometriosis, but it is the beginning of the practice. So you need to do a meticulous ultrasound examination, and most of the things which I have seen, I think we may not be able to see it in the laparoscopy or the surgery. So once your diagnosis is correct, I think a proper door we can show to the patient the various treatment options needed. Thank you so much.
Any quick questions from the audience? There are no questions. I think, Shri, that was a wonderful image gallery that you presented. Thank you.
Thank you.
It's a privilege to introduce our next chairperson, Dr. Shamundi Shankari. Dr. Shamundi Shankari has 39 years of professional experience in the field of fertility, and she is a former professor of microsurgery, obstetrics, gynecology department in Government Keel Park Medical College. She received Lifetime Achievement Award from His Excellency, the Governor of Tamil Nadu, Dr. Rosaya, for her achievement in the field of fertility services, and Orlando's Association of Medical Graduates deemed Dr. Shankari as the best physician in 2001. Dr. Shamundi Shankari is the founder and chairperson for Shrishti Fertility Hospital Private Limited. She is a managing trustee of Shrishti Medical Research Foundation, and she is a chief consultant at Shrishti Multi Specialty Hospital, who extends ongoing research in infertility, genetics, and andrology. She was bestowed with WHO Fellowship in the year 1985 at KK Hospital and Professor S.S. Ratnam, and 3 months observership in IVF and infertility and reproductive surgery in Bayer College of Medicine in USA. Diploma in operative laparoscopy at University of Kiel, Germany, and she was appointed as the observing faculty for 1 month in Sydney IVF and Genetics Center, and Senior Vice President of InStar Research. We welcome you, ma'am. I request you to introduce to our speaker, Dr. Ramachandra, sir.
Thank you. Thank you very much for the introduction. Good evening, everybody. I thank Dr. Sanjeeva Reddy and SMART to have given me this opportunity to introduce the speaker, Dr. Ramaraju. I think all of you are very well aware of his achievements in the field of time-lapse and other IVF procedures. Whether time-lapse is necessary or not, that he is going to enlighten us now. Whether it's going to improve the success in IVF, all that we are going to listen to his lecture and then decide. Thank you. Can I have his?
Thank you, madam, for the kind words. First of all, my thanks and congratulations goes to the team of SRMC, especially Dr. Sanjeeva Reddy. And I'm proud and privileged to be part of the faculty and enjoying the sharing of knowledge for the last 5 to 6 years. And we at Krishna IVF share and treasure all the individual moments which we have with each of the student, and more than that, we learn a lot by teaching them. In this lecture, I'll be taking you to a journey about the time-lapse incubation and monitoring, and it's beneficial in the field of assisted reproduction. When we look back at the assisted reproduction in the last 45 years, we find there are major changes and minor changes. The major changes are the advent of the first IVF baby in 1978, and in the mid-90s, it's the advent of the ICSI and the testicular sperm extraction which made a difference in our practices. And in mid-2000s, the advent of embryo vitrification and later the oocyte vitrification has radically changed our field. In between, pre-implantation genetic diagnosis is popping up in terms of FISH analysis, CGH, and now NGS, and time will tell is that the changing environment. In between, time-lapse has also been competing as a major change in the reproductive medicine. Only time will tell us whether that is true or not. Before I go into the details, I would like to show a film about a time-lapse video. Here in a time-lapse video, you have the incubator where you have 16 chambers, and then each chamber is photographed every 5 minutes in 11 planes, and these are stitched together as a film. And then you'll be able to analyze it. Here we are seeing the appearance of the 2 pronuclei, the 2-cell division, the 4-cell division, and the 8-cell division, and later the compaction, and finally the blastocyst formation. In time lapse, what we see is what we see in glimpses of 24 hours, we are looking at on a continuous basis and then understanding the nitty-gritties of the embryo pharmacogenesis. One might think the time lapse is a relatively new technology, but the first publication happened as early as 1929 in the Science Journal, in which Lewis and Gregory has published a paper called Cinematography of Living Developing Rabbit Eggs, and it was almost 92 to 94 years back when the concept of time lapse has come in, and now it has become better with the advent of better computing technology, digital imaging, and graphical manipulations. As we look at how the evolution of embryo morphological development evolution happens in the laboratory, they can be classified into 4 groups: a single point morphological assessment, continuous embryo monitoring, using manual algorithms, using automatic image analysis platforms. For many years, single point morphological assessment was done, but the landmark paper by Pei in Human Reproduction in 1997, she first demonstrated the use of time lapse in humans and published the findings in the Human Reproduction Journal. Subsequently, between 1997 and 2011, there were a lot of innovations in the culture conditions and the culture media that are used in the time lapse. And from 2011, the development started progressing at much faster pace, and more so from 2008, where automated analysis of the platforms have come. The platforms are around 5-6 models. Each has its own advantage and disadvantage. But if you look at the first incubator in which Louis Brown was cultured, that is a flask in which Edward cultured the embryos of Louis Brown, and it's kept in one of the museums. From that point, we have moved a lot in this last 45 years. And for many years, all of us were using the box incubators, later the desktop or the Mink incubators, which were serving the purpose. Now with the advent of technology, as in every field, like our standard telephone, we have moved to mobile phones, where we have used the computing technology, the wireless technology, the power of algorithms to use that knowledge. Similarly, in the area of IVF, we have the time-lapse incubators. These time-lapse incubators come in various sizes. The one which we use has ability to culture 6 patients at a time. The temperature is controlled by inbuilt sensors, and the images are taken in 11 planes every 5 minutes, and it maintains undisturbed culture conditions for 5 days. And the light is modified so that longer wavelengths are used so that there is no harmful effect of light when photography. And these incubators are humidified. Unlike the box incubators which were served for many years, the problem was they were basically biological incubators modified for our function. In the subsequent years, the conventional incubators have come in, and later the time lapse. So in time lapse, basically you are using a combination of monitoring the embryos and tracking the progress of the embryo and maintaining a stable environmental conditions. If you look at what are the conditions that affect an embryo, it can be the embryo cleavage, it can be age, the cause, the stimulation protocol, the ICSI, the media, the handling, the maturity of the oocyte, the oxygen saturations, temperature, pH biopsy. In time lapse, you're removing the media because you're using a single media. You're removing the concept of handling because you don't disturb the embryos for 5 days. The oxygen is automatically, and the CO2 and the humidity as measured. So out of the 12 parameters, you have removed 6 parameters in the automated measurement, which in turn brings a little more stability than what is done manually. In a conventional lab, depending on the workload and depending on the number of pickups you do, your timing of embryo assessment varies. You do it on the day of the egg collection, you do it at the end of 24 hours, or you follow the Istanbul consensus and do it at 16.5 hours. Then you wait for the 2-cell division, which is before 30 hours. Then depending on the policy, whether you're doing the 2-cell embryo day 2 transfer or day 3, you check the embryo again depending on your workload on the 2nd day or the 3rd day. And if you're doing a blastocyst transfer, you might skip the 4th day and go into 5th day. So in a conventional observation, you're just looking at 5 to 10 points of the whole embryo journey of 120 hours, whereas in time lapse, you're continuously looking at the whole embryo development. We will be surprised to know that in the first 24 hours or 30 hours, there are 13 critical events which affect the formation of the blastocyst and the implantation rate. The 13 critical events are the timing of the exclusion of the polar body, the appearance of the pronucleus, the juxtaposition of the 2 pronuclei, the pronuclear fading, the beginning of the 2-cell division are some of the examples which have an impact on embryo implantation and live births. Here is a beautiful publication by the Italian group which was published in 2016 titled Focused Time-Lapse Analysis Reveals Novel Aspects of Human Fertilization and Suggests New Parameters of Embryo Viability. This group have worked on a series of embryo information, and in this on the y-axis you have the hours in which 0 hours, 20 hours, 40 hours, 60 hours, 80 hours. On the x-axis, you see the polar body exclusion, female pronuclei, the cytoplasmic halo, the female pronuclear breakdown, male pronuclear breakdown, and you will be surprised that so many events happen within the first 30 hours. And in a conventional laboratory, we see maybe once or twice these embryos, and we miss this information, which have a lot of implication. The second group is post 30 hours, you have a series of events of the 2-cell to the blastocyst, and the correlation of the 2-cell to the 4-cell or 2-cell to the compaction of the embryo or 2-cell to blastocyst all give us an idea about the possibility of a good blastocyst and implantation. One can plot the timing of these embryos into minimum and maximum pattern and then plot them, and if you are getting an embryo within these timelines with good morphological criteria, then your possibility of pregnancy pickup or positive pregnancy with the transfer embryo is becoming better. If there is a deviation in the time lapse compared to one embryo which is falling within the minimum and the maximum, the pregnancy rates are differing. What are the critical learnings from the time lapse? One is the change in the fertilization check time, missing the abnormal cleavages, be it the direct cleavage, the reverse cleavage, and missing the delay in the cell division timings as applicable to the blastocysts, which I will be emphasizing in a publication where 78,000 embryos were analyzed. It was realized that if you follow the Istanbul consensus of 17 hours of embryo check, you might miss 8% of ICSI fertilized zygotes as non-fertilized, and 10% of IVF-derived zygotes are likely to be classified as unfertilized, because by that time the 2 pronuclei disappear. So there is a need to change the classification and the timing of the fertilization check, and it should be done much earlier. And this data is a robust data of showing close to 78,000 embryos where they analyzed optimization of timing of fertilization assessment for oocytes cultured in standard incubator, lessons learned from time lapse out of 78,000 incubator. There are many parameters which affect the outcome, but I will be going into the details. Apart from the timing of the embryological events, you might find a good for day 4 embryo or a day 3 embryo or a blastocyst, but not all good embryos are morphogenetically similar. Some of the embryos which you consider excellent are actually abnormal, and they are transferred in an IVF lab, and time lapse helps to identify that. And I am going to show you 3 examples of those. Here I am showing the direct cleavage, what happens. Here is a cartoon showing 46, then you have an extra blastomere which starts dividing and it turns into blastocyst. That's where you sometimes find the mosaic pattern. So as you see in this, there is an appearance of 2 pronuclei. Then you find a 3-cell division instead of a 2-cell division, and the 3rd cell is not dividing at the same pace as the other cells. With time, the 3rd cell is dividing into 2 cells and again fusing back together at a later point of time. And if these form into blastocysts and you do a blastomere biopsy, you can have a mosaic pattern embryo. See how it is forming a blastocyst with the extra blastomere outside. And if your biopsy is not proper, you pick up part of that cell and then you get a mosaic, and then you are confused whether to transfer or not to transfer. And then the data shows that not all mosaic embryos are bad, because here this mosaic embryo showed a single blastomere which is separate from the other cells. Then you have the concept of reverse cleavage of embryos. Here you find a pronuclear formation at this point. The second pronucleus is here. The cytoplasmic wave, the halo is coming in. Then the disappearance. Then it's dividing into 2 cells. The cartoon is showing the number of cells in the right top hand side corner. Then when you look at the cell at the 12, it is joined by 2 cells. So the topmost 2 cells have 92 chromosomes and the other cells have 46 chromosomes. But when we look under a microscope at a specific point of time, we say satisfactory embryos and transfer them. Then the concept of three pronucleus. Here, one of the polar body is not excluded and becomes a pronucleus. These are two pronuclei, and a little later you see the third pronuclei. This is the third pronuclei, 1, 2, 3. And these fuse together and form a 69 chromosome pattern, also known as the triploidy. But you will be surprised that it divides like a normal embryo into a 2 cell, then into a 4 cell. If you are doing a day 2 transfer, you say an accident embryo and then blame the uterus. And going into 8 cell, the surprising thing is these embryos also go to blastocysts effortlessly. Here it is for becoming a morula, compaction morula. Then you're going to see a blastocyst. If you transfer and then you think that something is wrong with me or with the uterus or with the lab, but it's the embryo that's wrong. Then there is a recent publication in 2021 which is based on the rate of cell division. The evolving information suggests euploid, mosaic and aneuploid can be picked up, but much more work should be done. They have studied a significant number of embryos, and on the y-axis you have the number of hours. On the x-axis is time to the start of compaction. This is time to start a blastocyst formation and the blastocyst formation. The green is the euploid embryos, the gray is the aneuploid, the blues are various degrees of mosaic pattern, and when you look at the box plots, these box plots, the median values are different for each of these embryos, and further refinement will in future help us to pick up euploid, mosaic and blastocyst embryos based on the rate of the cell division. Finally, what I would say is the benefits of time-lapse incubation gives better culture conditions, uninterrupted culture conditions, gives lot of information which we are not aware for the last 40 years, and the understanding of time-lapse morphology is really redefining the embryos. Based on the evidence, time-lapse brings the information of the embryology into the clinic, and it demystifies the embryology. On behalf of my team at Krishna IVF, I thank the SMART team for giving me the opportunity to share this journey of knowledge. Thank you.
Thank you, Dr. Ramachandra, for the vivid and the beautiful presentation on time-lapse. Time-lapse facility in a IVF center gives, as you said, more success than the usual one. But not everybody can afford the time-lapse, this one.
I look at this way, ma'am, two things.
Yeah.
Technology makes us make less mistakes. That's one thing. Second thing is, with time, technology cost comes down. So it's the one we bought 2 units because we completely changed into total time-lapse unit, and it costed us 2.3 crores. But with time, what happens is the cost of technology comes down.
Is it Genia, by Genia or?
This is by Genium, but there are various models are there. But one should look at there are a couple of things one should look at when they're buying a time-lapse equipment. One is, can a different media be used other than what the company proposes? Second thing is, how many pictures does the camera take per exposure. Some take 5, some take 11, some take 16. That will tell you the clarity of the image and what is the frequency interval between each image, because you might miss the events. And how many oocytes can you culture at a single time? This genium makes 16, some have 9 or 10, others have 20. Then how many patients should an incubator hold? All these are important information before making a decision. What I feel is time-lapse will make us better knowledge workers rather than technicians. That's one thing. And second thing is, in future, I would look time-lapse more as a deselecting an embryo rather than selecting an embryo.
Embryologists should be trained very well, no? Embryologists for all this, because we can't go and see all this time lapse.
Like what happens is, if the algorithms are there which will provide every information, and that comes at a cost. If you don't want to cost, then the embryologist to study, read and become a knowledge worker. Otherwise, they should move from a technologist to a knowledge worker.
That exposure so many photographs that won't affect the blastomeres in situ as such.
The light that is used, it is at a longer wavelength and at a shorter frequency. Those studies were already completed. So, so, yeah, what happens is there are two types of 3PN. In the male, where it is not male, it doesn't got extruded. If it's a female 3PN, you find one polar body and one no polar body. If you find two polar bodies with 3PN, then male is the cause. If you find 3PN with one polar body, then the female is the cause for that abnormality. The answer is no at this moment of time, because the concept of 3PN giving to viable embryos and blastocysts, earlier they thought they should be thrown away. Now they're thinking, if you don't have an embryo, do a PGD and then verify the information by PGD before you confirm it. But my answer for your question, the exact answer is, I don't know.
Sir, retrospectively, suppose if you would have kept the timeless incubator, would have been founded and throw the embryos out?
No, the answer is here time-lapse is picking up triploidy, but here it's one extra chromosome abnormality. It may or may not pick up, that's my guesswork.
Dr. Raju, I have a layman's question for you. Then usually, you could find so many abnormalities in the embryos, no? But when it comes to the babies, no? But the abnormalities are not more than in the general population, no? When it comes to the IVF babies. How could you explain that one?
Now, these are embryos where we crib saying the blastocysts are good, the embryos are good, it did not implant. Some of them form into that group.
Many centers, they don't have the time-lapse video monitoring. No?
No,
so
no,
only
what?
very few centers are there. But in general, if you take it in general, the abnormalities, no, we are by looking at the morphological characteristics, we presume that they are good embryos and we'll be transferring them. But the abnormality rate is not that high in IVF babies compared to the general population.
No, what happens is we are speaking about live birth, and here we are speaking about implantation rate.
Okay.
These embryos will not implant.
Did you see the difference between you before doing this Mink incubator or other incubators? Now with these two, when did you buy this two?
2019.
19. So the difference between the study, you have a study about it, how much the improvement of your fertilization rate and success rate and the implantation rate, take-home baby rate?
What happens is, in the past 2.5 years, we rarely transferred more than 2 embryos. That's one thing. Second thing is, we do day 4. We do day 4 for the last 15 years.
Well,
I mean, by the time morula forms, by 90 hours, if your morula does not form, your embryo is suboptimal.
so when these embryos are abnormal and if they are not going to implant, where is the need for the video monitoring? No? So that we can, whatever embryos looking good, no, we can transfer them and we can.
No, here what happens is, here this is what we are seeing in a conventional lab or a few more times. And this is the information time-lapse is giving in the first 30 hours. So the appearance of pronuclei, disappearance of the pronuclei, if they're going late, then they have less chance of a blastocyst formation and a less chance of implantation. If your first cell division is not completed by 30 hours, the chance of that embryo giving a higher implantation rate is lower. So there are two things here, the rate of cell division and the morphological events with controlled environment are the key for time lapse. This is an additional information, nobody realized it has existed, and this is bringing out now. Earlier we did not have the information, and it's giving new dimension to the field of embryology between the first 48 hours. And what they're doing in AI is just identifying that cell and saying it's appearing and giving a score and then predicting the blastocyst. And we are taking it as a foolproof because none of us were exposed to the concept of so many events in the first 24 hours. It took us 1.5 years to understand these events and to assimilate it into clinical work. The second thing is, I am saying we use time-lapse to deselect an embryo, not to select an embryo. The other thing is, the extra embryos which we allow to be frozen are also should not have adverse time-lapse events before we freeze them, even though they're good blastocysts. So that way, if you have a lot of blastocysts, sometimes you might have 10 blastocysts, you keep on transferring, but none of them implant. They are the groups which are having abnormal cell divisions because you have given too much of dosage, stimulated too high, and producing aberration of cell divisions. So there sometimes we are ending up only selecting 3 or 4 embryos because of the either 3PN, single PN, reverse cleavage or direct cleavage. That whole number of embryos are eliminated. That way, the other embryos which you are transferring has a high potential of pregnancy. So our experience showed the number of freezing embryos per patient has decreased, but those embryos are giving equal pregnancy as a fresh embryo. We routinely practice only fresh embryo transfer and allow the other embryos to go to blastocysts and then use the morphokinetic to select it. Not even once, only unless the patient wants it and fights with us.
So you don't see the difference between the freeze-all and people, everybody is enjoying really the good results of freeze-all technique rather than fresh.
We never did it, so we are happy with what we are doing.
So
I'm not saying it is wrong.
Yeah.
But basically, we were comfortable
All
with
PCO patients you're not getting in your clinic? PCOs, OHS, PCOs and hyperresponders, definitely you would have had. So that them also you did a mild stimulation or fresh transfers like that?
Yes.
Yeah.
The only time which we postpone is if the patient lands in OHSS with significant fluid. That's the only time we postpone the embryo transfer.
Yeah.
And there the criteria we take is a significant amount of change in the PCV plus volume of the fluid.
Okay.
There we change the policy from 2 embryos to single embryo.
That's good. So, your sincere advice for all of us to buy a
No.
time-lapse labs?
No.
Is it being-
My advice is study.
No, this is scientifically you are proving.
No.
So, we had to accept the truth.
No. What happens?
Sincere advice. I want to share some of the things about Dr. Ramaraju. Even though I went to US and came back, there are so many things will be there, short things that nobody helps you. When we started our center, he was troubleshooter to us. Many times I disturbed him, he was helping us. Not only that time, from the time I started MCH and MSc Clinical Embryology, every year our students will go and spend with him 15 days every year. They are teaching them freely, like that's one greatness of him. Other thing I want to share with you, his brother-in-law and myself, we worked in Jipmar, Pondicherry. So whatever money he earns, he invests in the real estate. Half of Vizag is his thing. Whatever money he earns, he invests in this type of things. So what we will do, if some equipment comes or something like that, we will see 2 or 3 papers, then you will take a decision, this is good or this is not. What he does, any equipment or any technology released in the world, he buys, he uses. If it is satisfied, he will be using, he is convinced. If it is not there, he will keep in one corner. You go to his lab and things, so everything will be there, it will be on the side. He is not convinced. That way, he is a thing. So if you want to do like that, tomorrow onwards, we are also going to buy all the things, then we are going to take decisions, okay?
The evidence has not supported for increasing the live birth rate, neither for decreasing the miscarriage rate. The recent Cochrane analysis, Cochrane review, and many publications also have not supported increase in live birth rate with time lapse. Certainly it is a better, it certainly provides better culture conditions, reduces human error, reduces human factor. I wouldn't say human error, reduces human factor, and definitely adopting new technology has to be a way forward, like you said, and also technology will reduce, cost will reduce with time. But as of now, what you said is probably not right, because it has not really transferred into increased live birth rate as reported by the current literature.
I would like to add one point there.
Yeah. Yeah. No, that's good. But if you look at the recent evidence.
I would add to one point.
Yeah, and also we have to keep in mind that our...
No, I'll add one more point. Here what happens is, when you look at total time-lapse clinics versus patient-selected time-lapse, there's a bias in the selection. There are only few centers in Europe which do total time-lapse. So there's a bias in the selection of the patient itself in the data. No. What happens is, some of the studies...
just about 20% of clinics in US will have. I don't know about the European. I have this data because I recently had a talk.
What happens is, when you look at the data, is that clinic total time-lapse clinic? Or is it paid for fee? Except Scotland, all other places, it's paid for fee.
For what? You have to pay for the time lapse?
Yes.
Okay.
So then there's inherent bias in the studies.
Look, we can always discuss about
that's
the
one
studies,
thing.
but we have
the
to,
second thing
kind
is,
of...
my advice to everybody is, look at the morphokinetics of the embryo, understand what is happening in our field is the first thing one should do before venturing into the time lapse.
Yeah.
I started working on time lapse in 2015.
Yeah, that's good. And also we have to remember that our fraternity or our specialty is a lot industry driven. We can't deny that fact. Whether it's laparoscopy or whether it's ART, it is industry driven. And so it is what is drilled into our minds also influences our decisions very often. But if we also have to depend on something. I also agree that there are so many questions on the evidence that is published. Like you said, it can be biased, yes. But then we have to go by whatever is published evidence at this time. So I got up because you said that, so we'll buy the time lapse.
Because what happens
We don't
is,
get embryos, all very good embryos, as he said, it's not implanting. We don't know the reason. Endometrium is good, embryos are good, our embryology is too good, but nothing is implanting. So that sort of patients who are repeated failures, at least, every clinic should have at least one time lapse and to study about it, but we should know, like Sir Ramaraju sir, scientifically, we have to get into this and we have to do it. Yeah, same cost, otherwise they will not come, patients will not come.
there is
Same
one more problem if somebody buys one incubator, because they will be forced to buy the same incubator because of the disposables and the media and the annual maintenance contracts that are there with this. Because the culture dishes for the two different types of time lapses are radically different. They don't fit each other. So I would advise, one is looking at morphokinetics, understand morphokinetics before they venture into the time lapse. That's my advice.
So with time lapse, you do more of fresh transfers than frozen.
No, irrespective of time lapse, before also we only do fresh transfers, ma'am.
Thank you very much.
Yes.
And you can watch his lectures in Facebook and Instagram, and he has written many books. You can go through that.
Yeah, real scientist.
I would like to call upon the dais our next chairperson, Dr. Vijaya Ganesh. Dr. Vijaya MBBS from Madras Medical College, Chennai. A Masters in Human Genetics in Department of Human Genetics, Ramachandra Institute of Higher Education and Research. PhD from Department of Human Genetics in Ramachandra. And she is a secretary of TAPISAT in 2022 and felicitated on Doctor's Day at Madras Medical College by TIMA in 2018. She is an executive committee member in TAPISAT 2016 and Best Doctor Award bestowed by Dr. MGR Medical University, presented by Governor of Tamil Nadu at Rajbhavan 2014. I would request you to introduce to our speaker Dr. Sujata Karma.
Thank you very much for a nice introduction. And first of all, good evening to all. And first I wish to congratulate SMART, the Department of Reproductive Medicine and Surgery, Ramachandra University. And I thank the SMART department and Dr. Sanjeev Reddy sir for giving me this opportunity to be a chairperson. And also it's my pleasure to introduce Dr. Sujata Kar. She's a practicing gynecology endoscopist. And also she is an expert in assisted reproduction for the last 25 years. Her area of interest, polycystic ovary syndrome, proteomics of male infertility, scope of stem cells in gynecology. And her major achievements are she's a best graduate, she's awarded many gold medals. And she's credited with the first IVF baby of Eastern Orissa, first TISA, frozen embryo, laser hatched embryo, so many things. And also she's been awarded from the Honorable Governor of Orissa and Chief Minister of Orissa. And she's presented many papers. And now I invite Dr. Sujata to deliver her challenging topic, uterine abnormalities and reproductive outcome. This is where whatever the embryo's quality, however the embryo, whatever the good quality embryo we produce and we get it from the time lapse, it's finally the uterus has to decide whether to implant or not. So this is a very challenging topic, uterine abnormalities and reproductive outcome. Over to you, Dr. Sujata.
Pointer.
Pointer. Which one? So, good afternoon. Thank you very much, Vijaya. Nice to meet you. I was looking for the secretary of TAPISAT. Dr. Sanjeeva, thank you very much for inviting me. I have attended your conferences earlier of Ramachandra Institute, and this is the 10th year. Congratulations. And I hope you're not going to wait for the 25th. You're going to have it every year, and we are going to enjoy coming and having such great academic feast. So my topic is congenital uterine anomalies and a reproductive outcome. I'll try my best not to make it a boring subject like it is usually expected when we are doing our post-graduation. So the first accurate description of the shape of the uterus was by Leonardo da Vinci in the 15th century. He made a pretty accurate description of the uterus with its all the 3 layers, with the blood supply, everything. Before that, there was the common knowledge that the uterus in the human female is also multi-compartmental. So he depicted it very nicely, made only one mistake. He made the uterus absolutely spherical. There is so much debate as to why he did that, but this was the first accurate description. Since then, we have had descriptions of so many variations in the shape of the uterus, as described by the various anomalies of the Mullerian ducts. Overall, in a very broad way, the agenesis and hypogenesis anomalies, the unification defects, and the canalization defects. Today in my lecture, brief overview about the classification, incidence, diagnosis, likely pathophysiology, the reproductive outcome in a nutshell, some good practice points for the 4 major anomalies that we most commonly see, the T-shaped uterus, whether it's a myth or a reality, and I will end with some key takeaways. And all the recommendations and the data that I will be presenting is from 2 very recent articles published, 2021 and 2022, a very extensive systematic review, meta-analysis, and a practical consideration on congenital uterine anomalies. So I'll be quoting from these 2 very recent studies. We know that till now we have 3 very broad classification systems. The AFS, the oldest since 1988, it is based on Mullerian developmental abnormalities. There is no clear-cut diagnostic criteria for each of the abnormality, so it's very complicated, not many people like to use it. Then comes the Eschre ESGE. I find it the easiest. It is based on the anatomical abnormalities of the uterus, cervix, vagina, and just like FIGO classification, it uses uterus, cervix, vagina, and gives you a very clear-cut diagnostic modality, and it's pretty simple. I quite like it. But the most latest one is the ASRM MAC 21. It is very extensive and very good because it utilizes anatomy and imaging criteria, the most recent imaging criteria of 3D and MRI, and it also defines, takes into account uterus, cervix, and vaginal abnormalities and complex abnormalities. And in that classification, you get 9 different abnormalities. I'm not going to, don't worry, I'm not going to read each one of them. It defines 9 abnormalities that almost covers all. The best is maybe you can take a printout of this, sheet or this diagram or this table and put it in your, paste it in your OPD, and then it will be very easy for you to make any diagnosis. So incidence is very interesting. There has been wide variation reported, obviously because the diagnostic criteria that are used are, this is not working, The diagnostic criteria that are used are very variable, and the system that is, classification system also is very variable. But it's very interesting to note that, of course, this I have reported, I have taken down, I have compiled. And it's very interesting to note that in the 4 categories of patients, the highest is in the category of patients which suffer both infertility and miscarriages. So you have about a 25% rate prevalence of abnormalities of the uterus overall in a category infertility and miscarriages. And septum, uterine septum of various types is the highest subcategory that you find. We know that making an accurate diagnosis is very important if we have to decide whether a surgery is required or not, and what kind of complications the patient might suffer if the patient is pregnant. So it's very important to to be able to counsel about the reproductive outcome or reproductive potential or prognosis, to know, make a proper diagnosis. Now, to make a proper diagnosis of uterine anomaly, it's very important. The only most important thing is if we will be able to see the outer contour of the uterus and the inner contour of the uterine cavity. So, earlier diagnostic hysterolaparoscopy was the gold standard, and HSG and 2D ultrasound was used as a screening method, because how else will we directly visualize the outer contour of the uterus? How else will we know that the two tubercles of the remnant Mullerian agenetic tubercles can be seen other than a laparoscopy? But today the 3D ultrasound and MRI have become the best diagnostic modality that is available, and no longer diagnostic hysterolaparoscopy is the standard. Here is a diagram of a bicornuate uterus. Both, all the three parameters, all the three criteria, diagnostic modalities I have shown, the HSG, the MRI and the 3D ultrasound. You can see in both MRI and 3D, better so in 3D, you can see the outer contour of the uterus as well as you can see the inner contour of the uterine cavity. So now today the diagnostic accuracy of 3D ultrasounds compared to laparoscopy and hysteroscopy is highest among every other imaging modality, including MRI. So 3D is now considered even better than the MRI. Its accuracy is as high as 97.6% sensitivity and 98% specificity. So what you need is draw three lines, the serosal line, the interosteal line, and then a line at the apex of the indentation of the uterine cavity, and then you draw perpendicular lines and see the thickness of between each of these lines and the angle between the cornua, as I have shown you here, and it will be able to give you many of the diagnoses possible. Today also in my lecture I wanted to point out earlier that I am not going to, because this is an infertility conference and we deal with infertile patients more often and miscarriages, recurrent pregnancy loss, I am not going to cover the anomalies that result in primary amenorrheas and the various kinds of cryptomenorrhea. And these kind of people, the anomalies that I have shown you usually are diagnosed during the time that you investigate them for infertility or you investigate them for recurrent miscarriages. So pathophysiology, it is quite understandable that uterus is an essential organ in which critical phenomenon of reproductive processes occur, which includes sperm migration, embryo implantation, fetal development, growth, and finally labor and childbirth. So any abnormalities in this shape and size can certainly prevent the normal uterine function and the normal functions of the labor and outcome. So there are various possible mechanisms by which uterine anomalies can result in an adverse reproductive outcome. Embryo implantation can be influenced by the vascularity and thickness of the endometrium and the morphology of the uterine cavity. Uterine septum is known to be composed of fibroelastic tissue with inadequate vascularization of the endometrium, which reduces endometrial receptivity possibility is there. It does not provide a proper environment for subsequent placentation and embryonic growth, might result in poor deciduralization, placentation, uncoordinated muscle contractility, which might lead to preterm labor. As we know, that is one of the commonest complications in pregnancy. And of course, abnormal muscle mass and decreased connective tissue in the malformed cervix can lead to incompetent cervix. So there are various theories, but the fact is that these abnormalities can certainly lead to reproductive, obstetric, neonatal outcomes. So that I have, like I said, I have made it into a nutshell just to make it easy for you all to remember. The various outcomes: infertility, poor ART outcome, miscarriages, second trimester abortions, preterm, malpresentation, cervical incompetence, IUGR, IUFD, placental abruptions, increased cesarean sections, and then the different categories. So to put it in a nutshell, we can see that almost none of the abnormalities cause infertility other than maybe a dysmorphic uterus. All of them cause an increase in preterm labor. All of them cause an increase in malpresentations, placental abruptions, increased rates of cesarean sections. And the most interesting is that Dysmorphic, the arcuate uterus behaves almost like a normal uterus, almost. And dysmorphic uterus, there is very less data available. That is why I have put it as whether it is a myth or a reality. And now we should, let me get down to good practice points for infertility practice in these 5 major categories that we usually come across. The first is the unicornuate uterus. I have a lot of videos. How to put this on? Can you just help me with the cursor? It's not coming. Now this is playing, but the cursor is not coming here. Anyway, so unicornuate uterus, we know that it is of various subcategories, right or left with a distal atrophic uterine remnant. Just wait for 1 second, next one you will tell me. So these are the various, subcategories, like I have shown you the video in which it's a clean one-sided unicornuate and the other side is a small atrophic uterine remnant. Similarly, many other categories, subcategories are there. The 3D diagnosis is pretty simple. There is a single cornua. It is typically called a beaked or a banana-shaped uterus on a 3D ultrasound. And surgical corrections, there are not many publications, but surgical corrections have been attempted. I had quite a few videos, but I could not make it ready for this presentation today. So usually the purpose, the hypothesis is that, a single cavity, a banana-shaped cavity, you try to make it into a triangular cavity using a scissor, not any energy source, and open up laterally to make it a triangular cavity as much as possible. There are some publications, even in the recent IAGE conference, we had a live workshop and I demonstrated 2 cases of unicornuate where we tried to make it into a triangular cavity. So that is one possibility, and we can suggest to the patient, if you do that, of course, a good 3D ultrasound must have been done earlier to note the thickness of the myometrium on one side and before you decide to do a correction. Now, one other thing is that ectopic pregnancies are also very prevalent in women with unicornuate uterus. Although it is rare, but it can happen in unicornuate uteruses very commonly. This case that I have shown here was a case of massive hemperitoneum. My infertility IVF patient who got pregnant, but unfortunately had the ectopic in one of the accessory horns or a remnant of the uterus. Now, arcuate uterus is the one like I really wanted to talk to in today's lecture. Arcuate uterus behaves almost like a normal uterus, but the diagnosis with septate uterus becomes a question mark very often, and very often it is overdiagnosed as some kind of a abnormality. So, what is a arcuate uterus? Whether a subseptate term should be used or not, I would suggest that we should totally get rid of the term subseptate and we should only have 3 terms, which is a normal uterus, partial septum and a complete septum, and use strict 3D criteria or other MRI criteria to define which septum should be cut and which septums should not be cut. Incidental septal resection should not be done. I come across so many reports, so many discharge sheets where a hysteroscopy has been done and the surgeon has decided to has reported a subseptum and has done a septum resection. That kind of a incidental resection should never be attempted, because during hysteroscopy also one can have a lot of errors in making a diagnosis, because the septum thickness also will sometimes depend on what is the pressure. If the pressure is less, you might feel that there is a septum. So many possibilities are there, and now that I have been doing 3D ultrasound for quite a few years, so many different shapes of the uterus we come across, and making an appropriate diagnosis of a septum is very, very important, and a subseptate term should totally disappear. Seriously, I can't get this cursor, I don't know why. see, I want to put this one on, no? So how to do that? वो कर्सर यहाँ नहीं आ रहा है ना? नहीं, इसमें नहीं होगा।
USB mouse।
हाँ, नहीं, नहीं, इसको कैसे ऑन करेंगे अभी? हाँ, वो उसको रखो। वो किधर से आया?
इधर से चले जाएगा।
कहाँ चले जाएगा? इधर।
नेक्स्ट में।
अच्छा, अच्छा, ओके, ठीक है, ठीक है। I'll try. Yeah. Okay, so in my practice over these so many years, I have seen at least one case of spontaneous rupture of the uterus in the mid trimester, and her spontaneous rupture, and her only history was she had undergone a subseptum resection elsewhere a couple of years back, and that was really ghastly and it was really horrible. So one has to make a very, very informed decision about which septum should be cut and which septum should not be cut. For example, this is a video of a patient of recurrent pregnancy loss. If you see, you can feel that there is a small septum. Now maybe yes, there is a small septum, but really does this septum needs correction or it does not need correction? Is this a cause for a recurrent pregnancy loss? Should we just cut it because it appears like a small indentation during our hysteroscopy? That's a big question mark, and probably even for septum resection we know that probably under correction is better than over correction. So subseptate, this the whole point was to tell you that subseptate is absolutely normal. What happened? चार्ज नहीं, चार्ज तो है, चार्ज बहुत है,
49% है,
49 है। अरे बाबा, क्या हो रहा है? I'm so sorry. The last lecture, everybody must be thinking we should finish and go. आया? नहीं,
आ गया।
आया। Okay, so so basically the message is subseptum don't overdiagnose and avoid incidental correction during hysteroscopy. Now septate uterus, like I have mentioned, is the commonest type of uterine anomaly that we see in all category of patients, and whether it has many types of subcategories, I will not go into the details. We know that it can be partial septum. Partial septum is more than 1/3 of the cavity. In simple words, complete septum is up to the internal os. Complete uterocervical septum is uterus and the cervix complete, and then complete uterocervical and vaginal septum is what we have completely. The diagnosis by 3D is the criteria have been very well defined. The indentation of the external contour should be convex, or if there is an indentation, should be less than 1 centimeter. The internal indentation should be more than 1 centimeter or 1.5 centimeter. Strict criteria say more than 1.5 centimeter. The angle from the apex of the septum should be less than 90 or less than 75 by strict criteria, and the indentation wall thickness should be more than 110%. So some people use very strict criteria. I will be showing you why they do that, because they feel that septum is no good, it does not need correction. Now we know that there are different types of septum. Septum can be very thin. I have all kinds of septum here for you. Very, very thin septum, simple. Takes 5 minutes to get rid of it. Mostly fibrotic. Sometimes it's really thick and you start off and you are not sure how far you can go. Like in the lower one. Sometimes it's, I mean, usually it's supposed to be fibrotic, but sometimes it can be muscular also. And whatever the thickness, it has usually been shown that you don't need to resect it, just cutting it is enough. And in cases like this, it is better to keep coming back, deciding how much to cut, slowly, steadily, better to undercut rather than overcut. But see, look at the thickness, the you know how broad the septum is as you are going up. So one has to be very careful that you do not over resect. And then this is a complete cervical septum. enter with a vaginoscopy. There was a time when we used to there was a lot of debate on whether we should cut the cervical septum or not, and the last one is a complete cervical vaginal septum. Cervical, vaginal and uterine septum. So there are various types. One has to be, one has to do, one has to be careful, and one has to make a proper diagnosis and a proper surgical resection of these kinds of septum. Now, why I showed you all kinds of septum is that there is a lot of debate on whether to operate or not operate. If there is some field, just like endometrioma, whether to operate or not to operate, polycystic ovarian syndrome, whether to do drilling or not drilling, the reproductive surgeons and the reproductive specialists, the ART specialists and the laparoscopic surgeons are forever fighting over this issue. Similarly, septum is another issue for which there is so much of debate and so much of question mark, and the different countries, there are so much of different publications. So like I will show you some publications, the recent 2021 editorial in the Human Reproduction, it said that it is all too much, the shadow of over-treatment loops over hysteroscopy metroplasty for separate uterus. The editorial went as far as saying that the community of hysteroscopists should now feel somewhat embarrassed when realizing that septoplasty has been introduced into practice without sufficiently robust evidence. Whenever I have been to ASHRAE conferences and all, I am sure you all agree that there are so many lectures which is already based on whether septoplasty should be done or not, and there is a group of doctors, specialists who feel that septoplasty is overdone, it is not required at all. And so this was the most recent publication, 2021, of the TRUST trial, the only randomized controlled trial published till date for septoplasty for improving live birth rate, reducing miscarriages in women of with having a with a uterine septum. And you will be not surprised to know that the trial, they concluded that hysteroscopic septum resection does not improve reproductive outcome in women with a septate uterus. They showed that, and this was a 1-year follow-up. The same year, couple of months later, the JMIJ, the Journal of Minimally Invasive Gynecology, the surgical group published with a patient, 1500, almost 1600 patients, and they showed that infertile women, women with poor obstetric history, women without previous pregnancy failures and a diagnosis of septate uterus, in this category of patient, hysteroscopic mastoplasty is effective in reducing the risk of miscarriage and in patients in complete and partial uterine septum. So there is so much of confusion in published data that we have to take it with a pinch of salt, what we need to do and what we did not do, and this was another 2021 study. So the point of the whole exercise is to tell you that uterine septum resection is something which we do every time. I mean, if we see a patient with uterine septum, we decide to do a resection, right? But then that is not supported by data as of now. So we have to remember that. There are a lot of studies that show that septum resection might not improve the outcome. So the next is the bicornuate uterus. The 3D criteria is very clear, simple. We should have a concave external contour, indentation more than 1 centimeter. Right, I'll take about 1 or 2 minutes more. And the internal 2 full cornua, the angle should be more than about 110. And surgical correction, as you all know, that there are not many proponents or not very many people who accept surgery for bicornuate and didelphys uterus, but there are quite a few publications. The last I found was for 2015, very small number of patients. I personally have no personal experience with didelphys or bicornuate uterus correction laparoscopically. So that is a question which you have to answer yourself, but there are hardly any published studies. So the last of my topic was dysmorphic uterus. This is a term which we have started hearing lately, couple of years. In fact, we know that DES exposure and sometimes acquired Ashermans can lead to abnormalities like that. And myself, when I am doing so many 3D scans, I am seeing all kinds of uterine shapes which I am not able to fit into any of the known categories that we have read about in the years. So again the 3D criteria are very well defined. The T angle, the angle at the cornua should be less than 40. There should be a lateral indentation. So basically there is a constriction of the lateral walls of the uterine cavity. Depth should be more than 7 millimeters. The lateral indentation angle should be less than 130 degrees. And they are defined as, there are various categories. These are all my pictures from my patients. So T, the middle one is a T, the first one is I, and the last one is like an I-shaped uterus. All of them are supposed to be abnormal shapes, and all of them, these kind of dysmorphic uteri are likely to reduce your ART outcome. That is why if you see a dysmorphic shape of the uterus during your IVF or your infertility evaluation, the teaching is that we are supposed to correct it by doing a lateral metroplasty. This is a video showing just that. This is my last slide, and the next one is the take-home message. So this one is most likely an acquired dysmorphic shape of the uterus, the T-shaped. You can see how the two side angles are converging in the side walls. Almost always the correction is using scissors, never using electrical energy. Again, lot of evidence is gathering about this abnormal kind of uterine shape, which can result in reduced pregnancy rate following IVF or following infertility treatment. So that is how you do a lateral correction, and then the fundal correction. Try to make the uterine shape as much as possible into a triangular correct shape of the uterus. So some key takeaway points: no universally accepted standard classification for congenital uterine anomalies as of now. Accurate assessment of the internal and external uterine contours is critical for diagnosis and for classification. Previously, the gold standard test was a combination of laparoscopy and hysteroscopy. 2D and HSG were screening tests, but as of now, 3D ultrasound and MRI are most suitable for categorizing CUAs accurately. There is a lack of evidence for improving reproductive outcomes with surgical intervention, be it arcuate, be it septate, be it bicornuate, be it didelphys. We don't have much evidence. Undoubtedly, the negative impacts of CUA on pregnancy begin in the early stages and can span the entire reproductive process. Lack of data on individual CUA subtypes makes it difficult to draw clear conclusions about the exact subtype specific effects on complications and their underlying mechanisms. Accurate diagnosis before and during pregnancy is a must. Since CUA is associated with renal anomalies ranging from 5 to 30%, upper abdominal ultrasound, KUB ultrasound and MRI is mandatory whenever you find a uterine anomalies. Thank you very much.
Thank you, Dr. Sujata. Though it was a end of the day topic, but still you made it very interesting.
Thank you.
A lot of information, a lot of illustration. So thank you so much for your very good presentation.
Thank you. That's what I was saying. That I don't have any personal experience with the unification process. I haven't done any.
But I had a case like that. 3 times I had an implantation failure because the shape was, the cervix I am not able to see. It is like a flower. When you put the probe, ET catheter, just directly it goes into the fundus and traumatize.
Okay.
How gently I am also trying to do. 3 times implantation failure. Is there any? Because when I put an ultrasound,
the cervix is absent or the cervix
is like a flower after unification surgery. I don't know what happened.
Okay.
Somewhere they did, and the thing now after cervix is not at all a good thing. It's like a balloon, and if you put an ultrasound, it looked like 2 balls like that. Unification was not done properly. I think it's like 2 balls. One cavity is little bigger, right cavity. Left cavity is smaller. And always 3 times also I put in the right cavity only. Still she's not successful. Best embryos, everything is good. I don't know what to do. Is that any myometrial contraction of that thing is indenting here, affecting the...
No, it is possible that the cervical septum which was cut has made the cervix very, much dilated. Is that...
My thing is the other one. See, like two balls I'm saying, I'm putting one here, but these two are connected. Is that myometrial contraction is affecting the implantation of this right conova, that's like right side cavity?
It is possible like they say, but they have corrected it, no? So that correction might have created a problem.
Yeah, shall we again go for correction, put a laparoscope again, see what I don't know.
You can consider a abdominal circlage around the internal loss, the common internal loss.
Now why she fails?
Before her treatment.
Yeah, it shapes like an unicorn weight. Endometrium is thick, more than 9 millimeter I'm getting. Every time, 3 times she failed. I don't know what I'm going to do. This lady...
Cavity is unicorn weight?
It is looking like the conversation, I mean, unification was not done properly, I think.
Maybe sometimes you need second look surgery also, so maybe you should again do... You've done hysteroscopy again?
Hysteroscopy, one cavity only, other cavity is obliterated. I'm not able to go the right cavity. Only left cavity, right is okay, left I'm not going into it.
Then you should do a detailed MRI, I think. She may be having those Robert's uterus and all, which has partially, a hemi-uterus which is completely blocked away from the one side, one of the cornu.
Then I had a history, she's done a unification surgery.
But do another proper MRI evaluation, proper hysteroscopic evaluation, then only think about another correction. Otherwise,
I think second look laparoscopy is better.
Yeah,
right?
yeah.
I'll proceed. Next.
I have done more than 9 unification surgeries.
Okay.
Which is 6 of and 6 forties.
Okay. Bicornuate. Yeah. I have no personal experience with surgery for bicornuate.
Very.
Yeah.
Dr. Sujata, just for your, you had a doubt in the beginning. We had a TAPISA election recently, and I've been secretary, and sir has been promoted as president of TAPISA.
Yes, I heard, that's what I said. It is nice to meet you because I heard that you are the secretary now. Nice to know that.
Before we conclude the conference, as a token of appreciation to the team who have been involved in organizing the conference actively, we would like to felicitate them with the mementos. I request Dr. Samundi Sankari ma'am to present Dr. Sanjeev Reddy sir with a memento. I request Dr. Sanjeev Reddy sir to give mementos to the following people. Dr. Radha ma'am, Dr. Mona ma'am, Dr. Siddharth sir, Dr. Manjula ma'am, and to Inca Life Sciences, and Senora, wait. Senora. Spectra. Thank you, Inca Life Sciences, Senora and Spectra, without whom this organization would not have been possible. Thank you.
I'd like to call upon Dr. Manjula ma'am for vote of thanks and conclude this conference. Dr. Manjula ma'am is an assistant professor of clinical embryology in Sri Ramachandra, Department of Reproductive Medicine and Surgery, Sri Ramachandra Medical Institute of Higher Education Research. She is a visiting professor in Sri Balaji, Chettinad and Savita Medical College and Hospital. And she has 21 years of experience in assisted reproductive technology in IVF, and trained in Singapore, Denmark, and done an advanced embryology course at London, and chapter contributed in textbooks and papers published in international and national journals.
Hello, thank you for the introduction. Good evening, everyone. Today I feel incredibly honored and privileged to have been allowed to extend a vote of thanks on this special occasion of 10th year celebration of starting the first MCH Reproductive Medicine and Surgery in India. On behalf of the Department of Reproductive Medicine and Surgery, I would like to extend my heartiest gratitude to our esteemed patrons, Chancellor Mr. V.R. Venkatachalam, Pro-Chancellor Mr. R.V. Sengutuvan. A special thanks to our advisors, Vice Chancellor Dr. P.V. Vijayaraghavan, Dean of Faculties Dr. Makesh Vakamudi, Dean Medical College Dr. S. Anandan, and the management of the Srihar for accepting our invitation and for their valuable and constant supports and guidance. Sincere thanks to Dr. Sanjeev Reddy, the mastermind of SMART, and the head of the department Dr. Radha, and all the members of the SMART team who have contributed some or the other way to constructive activity for organizing this event. On behalf of a whole fraternity of our organization, I would like to propose a vote of thanks to all the respected faculties for taking their valuable time from your busy schedule and gracing this occasion with your warm presence here. We feel enlightened and believe that we got to learn many things from this conference. I thank the Hyatt Hotel for providing the place with good ambience for this program. I thank the audiovisual, catering, technical support, photography, transport and maintenance team for relentless efforts to make this program hassle-free. I would like to extend a vote of thanks to the pharmaceutical companies as well as the sponsors of this meetings, Inca Life Sciences, Senora, a division of Sun Pharma, Spectra, a division of Sun Pharma for the support. I would like to thank Clearnet for their continuous support. Last but not least, I would like to thank our delegates for making this event happen so beautifully. Finally, I would like to thank all your support you present here for making the time to be with us today and helping us make this event a grand success. Thank you, one and all. Thank you.